The first speaker is Dr. Sinu Elsa James, free paper 12.
Good morning all. Today the presentation is on a retrospective study of incidence of ocular trauma in tertiary care teaching hospital, South Kerala, India. So the purpose of the study is that etiology of ocular trauma differ in rural area compared to urban area, and it also differs in demographic or socio-economic classes. Ocular trauma is one of the neglected areas in ophthalmology which causes severe vision loss in the clinical setup. So the study was conducted to assess the different types of ocular injuries involving anterior and posterior segment of eye presented at emergency department and ophthalmology outpatient department of a tertiary care hospital. So the materials and methods, it was a hospital-based retrospective study which was conducted in Emergency Medicine and Ophthalmology Department of Pushpagiri Institute of Medical Science and Research Center, Tiruvalla, Kerala. It was done for a period of 2 years spanning from May 2021 to May 2023. Study populations were the patients with ocular injuries attending Emergency Medicine and Ophthalmology Department. Total sample size was around 487 patients. The inclusion criteria was patients with ocular injuries reporting to the emergency department and ophthalmology OPD who were aged between 5 and 80 years. Only ocular trauma less than 7 days of injury were included. Exclusion criteria were the old trauma cases. Data collection tools and techniques. On arrival to ED or OPD, the patient's age, gender, religion, caste, residential area, occupation, education were taken. Mechanism of injury including blunt or penetrating, velocity of the object. Then specific history including the date, time, place, whether it is RTA, circumstance of injury, characteristic of trauma agents, mode of injury were noted. Symptoms and signs, treatment or intervention already given, and the level of consciousness was noted. Then visual status before the injury were asked, that history was asked. Then basic examination including the visual acuity, slit lamp examination, intraocular pressure, dilated fundus examination, B scan, OCT macula and CT scan orbit if needed were taken. Following measures were taken during the eye examination precautions, that is use of eye shield to protect the eye. Then administration of systemic analgesics, tetanus toxoids or systemic antibiotics if needed. So coming to the results, in age-wise distribution, that about 38% of the patients were belonging to the category of 20 to 40 years, followed by 60 to 80 years, which constitute 16%. And sex-wise distribution, the more patients were males, that is around 62%. Coming to the mode of injury, in that the metallic foreign body caused the most, in most cases, injury was caused due to metallic foreign bodies, that constitutes 51%. Followed by wooden road traffic accident 21%. Then complications, most of the complications were caused due to the superficial metallic foreign body that causes injury to the cornea. Then total 487 patients participated in the study. 62% were males and 37% female patients. Most vulnerable age group was 20 to 40 years, and around 24%, 84% had unilateral involvement, and maximum number of patients were industrial workers followed by farmers. And the most common mode of injury was the metallic injury, that constitute 51%, and non-metallic injury by wood was 15%, and road traffic accident was 9%. And ocular trauma related complications were mostly due to the corneal superficial foreign bodies, which constitutes 51%. Then coming to the data analysis that was done by IBM SPSS statistics, and conclusion is that ocular trauma is one of the major worldwide cause of preventable morbidity and accounts for 500,000 cases of monocular blindness worldwide, and corneal injuries were the most common injury that was noted in our hospital, and the males were most commonly affected, that is mainly due to their job types or eye injury still remains a significant cause of vision loss, especially in the younger individuals, that is most patients were between 20 to 40 years. So we have to make a current emphasis on the safe work environment must be expanded, and we have to adopt a protective precautions has to be taken, that is eyewear in workplace is crucial for preventing the eye injuries, and prompt medical attention can help to identify the severity of injury and reduce the risk of complications. So these were the references. Thank you.
Cracker injuries and all during Diwali times and all, we get cracker injuries.
Sir,
Are they included here?
cracker injuries and were also came. Few injuries were there, but that the incidence was very low. That only 4 or 5 cases were noted.
Okay.
Thank you.
Good morning, everyone. Good morning, everyone. Myself, Dr. Parvati. My paper is on the topic the association between vitamin D deficiency and diabetic retinopathy in patients with type 2 diabetes mellitus. Diabetes mellitus is a large public health problem which affects more than 415 billion people in the world, and diabetic retinopathy is among the most common diabetic complication. Vitamin D is actually a steroid hormone that is produced in the skin after exposure to sun irradiation. There are a vast array of pleiotropic actions of this vitamin. It has been shown both in vivo and in vitro that vitamin D is essential for the regular insulin release in response to increased blood sugar level and thus glucose tolerance. Vitamin D has an inhibitory effect on the vascular angiogenesis, and vitamin D receptors are ubiquitously expressed in every human tissue including retina. Currently, there is conflicting evidence regarding the association between vitamin D level and diabetic retinopathy. The aim of this study is to determine whether there is an association of vitamin D status and diabetic retinopathy in patients with type 2 DM. Coming to materials and methods, it's a cross-sectional study done among clinically diagnosed diabetes mellitus patients in the age group 40 to 80 years, done at tertiary care hospital in Kerala. Study duration was 3 months and the total sample size is 48 with 24 patients in both of the age groups. Inclusion criteria is patients with type 2 diabetes mellitus in the age group 40 to 80 years. Exclusion criteria includes patients on vitamin D analogs, patients on medications which can alter the vitamin D metabolism, such as rifampicin and phenytoin, subjects with prior diseases that suggested baseline alteration in the vitamin D and calcium metabolism, such as hyper and hypoparathyroidism. Coming to data collection methods, patients' medical history was obtained and was divided into 2 groups based on their diabetic status and retinopathy findings after dilated fundus examination. The first group consisted of patients with type 2 DM with no evidence of diabetic retinopathy, and the second group consisted of type 2 DM patients with evidence of diabetic retinopathy. And their blood was tested for 25 hydroxy vitamin D levels and HbA1c levels. And 25 hydroxy vitamin D levels were interpreted as follows: less than 20 nanogram per ml was taken as deficient, 20 to 29 was taken as insufficient, more than 30 was taken as sufficient, and more than 100 nanogram per ml was taken as potential toxicity. The data was analyzed using ESR software version 1.54. Coming to the results, the mean age is higher in diabetic retinopathy patients, that is a mean age of 66.38 years compared to non-diabetic retinopathy patients with a mean age of 63.29 years. The gender distribution were comparable between the 2 groups. The vitamin D levels were significantly lower in diabetic retinopathy patients with a mean of 19.83 compared to non-diabetic retinopathy patients with a mean of 25.62. And HbA1c levels were significantly higher in diabetic retinopathy patients with a mean of 8.15 compared to non-diabetic retinopathy patients with a mean of 7.08. The duration of diabetes was significantly higher with diabetic retinopathy patients with a median age of 10 years compared to non-diabetic retinopathy patients with a median age of 5 years. ROC curve analysis was done to calculate the best possible cutoff value of vitamin D level as a significant predictor of diabetic retinopathy, and vitamin D level of 23.505 nanogram per ml was calculated as the most accurate cutoff point below which the patient had a higher risk of diabetic retinopathy. So you can say that 75% of patients with diabetic retinopathy had a vitamin D level which was below the cutoff value, that is less than 23.505 nanogram per ml, whereas only 37.5% of patients without diabetic retinopathy had a vitamin D level which was below the cutoff value. Coming to the discussion, our results indicate a statistically significant difference in the mean age between the 2 groups, with diabetic retinopathy patients being older. However, the gender distribution was comparable between the two groups. Vitamin D levels were significantly lower in diabetic retinopathy patients compared to those without diabetic retinopathy, and the ROC curve analysis further identified a cutoff value of 23.505 nanogram per ml for vitamin D, below which the patient had a higher risk of diabetic retinopathy. This reinforces a potential role of vitamin D as a predictive marker of diabetic retinopathy and suggests that maintaining adequate vitamin D levels may be important for preventing and managing diabetic retinopathy. The study also found that HbA1c level was significantly higher in diabetic retinopathy patient, and the duration of diabetes was also notably longer in the diabetic retinopathy group. It highlights a critical need for early diagnosis and management of diabetes to mitigate the risk of retinopathy and other complications. These are the studies that agree with the study, whereas studies by Alam et al. And Bonagdan et al. Shows no significant difference in the diabetic retinopathy status between the two groups. Conclusion: this study demonstrates a significant association between the lower vitamin D level and the presence of diabetic retinopathy in type 2 DM patients. Monitoring and managing of diabetic vitamin D levels may be a valuable compound of strategies to prevent or mitigate the progression of DR. And the identified vitamin D cutoff value can be instrumental in clinical settings for early identification of diabetic patients at a higher risk of developing diabetic retinopathy. Future research with our larger cohorts is needed to validate these results. Additionally, RCT is investigating the impact of vitamin D supplementation on diabetic retinopathy progression could offer valuable insights into potential therapeutic strategies. These are my references. Thank you.
Good presentation. How much do you give vitamin D? You say like you have to supplement for all your diabetic patients. So how much you gave?
The standard dose is 50,000 international units given weekly orally for around 2 months if the patient is found to be deficient.
Yeah, it is 60,000. 60,000 international units weekly once for 8 weeks, as you said. Okay, good.
Thank you.
Did you put any slide on the diabetic age? I thought you put the age 60, something like that. Did you have a slide on the duration of diabetes?
Yes, sir. The median age was found to be 10 years in patients having diabetes without retinopathy, and 5 years in patients having diabetes without retinopathy, whereas for patients with diabetic retinopathy, the median age was found to be 10 years of duration of diabetes.
So that is the normal.
Yes.
Compared to vitamin D levels, is there any difference?
No, sir.
That is important, no?
Okay. Thank
You
you.
told when severe deficient patients can be given vitamin D every week. Severely deficient patients. What about the normal patients who need maybe required vitamin D or not daily?
Daily it is 400 to 600 international units daily dosages.
You are giving to the patients.
No,
Will it
not giving.
Then how you are told now you have excluded phenytoin? Exclusion phenytoin, how does it prevents vitamin D absorption? Whatever things deficiency. Phenytoin you told no anti-epileptic drug. You have excluded those drugs who are taking phenytoin and all from the study.
They have said to impair the absorption of vitamin D.
Absorption of vitamin D from where?
Yes, sir.
Which intestines? Which intestine?
Not sure, sir.
No idea. Okay, thank you.
I hope only the presenters are there. Is there any presenter absent? Somebody else going to talk instead of your presenter? As per all our presenters are ready. All the best.
Next is Dr. Adira K.
Good morning. My topic is measurement of central macular thickness using optical coherence tomography in patients with type 2 diabetes mellitus without clinical retinopathy and non-diabetic population, a comparative study. Introduction. Diabetes mellitus is one of the most prevalent health diseases throughout the world. Studies have shown that 34.6% diabetes develop diabetic retinopathy with time and is one of the major causes of blindness. According to study, there was significant increase in macular thickness in patients with diabetes without clinical retinopathy compared to non-diabetic population. Detection of increase in macular thickness before development of clinical retinopathy help us to review the patients more frequently and advise them adequate control of the blood sugar. Aims and objectives. Aim is to compare central macular thickness in patients with type 2 diabetes mellitus without clinical retinopathy to non-diabetics to evaluate association of central macular thickness with duration and control of diabetes. It was a hospital-based cross-sectional study and was conducted among diagnosed type 2 diabetes mellitus patients and patients without diabetes in age group 18 to 70 years attending OPD. Study duration was 1 year. Sample size was calculated based on previous study by David J. Browning et al. 88 eyes of patients with type 2 diabetes mellitus without clinical retinopathy was taken as study group and 88 eyes without diabetes mellitus was taken as control group. Sampling method was convenient sampling. Inclusion criteria: patients with type 2 diabetes mellitus coming to OPD based on WHO criteria. Duration 0 to 20 years. No evidence of diabetic retinopathy. Exclusion criteria: visible retinopathy, glaucoma, uveitis, ocular trauma, intravitreal injection, high refractive error, use of drugs for retina problem, previous ocular surgery, treated diabetic retinopathy, any other macular pathology, patients having gestational diabetes mellitus, media opacities, nephropathy, dyslipidemia. Method of data collection: cases were collected from already diagnosed diabetes patients and whose FBS, PPBS, HbA1c reports were available. Controls were taken from those who attend hospital for a health checkup based on their FBS, PPBS values. Age, gender, duration, mode of treatment were recorded and comprehensive ocular examination was performed. Results: mean central macular thickness in diabetics without clinical retinopathy was 241 micrometer and non-diabetics were 217 micrometer. And on comparing central macular thickness between diabetics without clinical retinopathy and non-diabetics, it was found that there is an increase in central macular thickness in diabetics without clinical retinopathy compared to non-diabetics, and the difference was statistically significant. On comparing gender, there was no significant difference in central macular thickness and gender in both diabetics and non-diabetics. And on comparing age also, there was no significant difference. As the
Deep breath, man. Relax and talk. There's don't worry at all. Relax and talk.
As the duration of the diabetes increases, there was increase in central macular thickness and the difference was statistically significant. As we changes from lifestyle to diet to OHA and insulin, there was increase in central macular thickness and the difference was statistically significant. More association was found with insulin. And on comparing, as the best corrected visual acuity decreases, the central macular thickness increases and it was statistically significant. And blood sugar, FBS, PPBS, HbA1c was also correlating with central macular thickness. As the blood sugar increases, central macular thickness also increases and was statistically significant. More correlation was found with fasting blood sugar. In this study, it was found that there is significant increase in central macular thickness in diabetics without diabetic retinopathy compared to non-diabetic group. There was statistically significant positive correlation with central macular thickness and duration and mode of treatment and blood sugar level. No association was found with age or gender. Conclusion: we can early detect increase in central macular thickness before developing clinical retinopathy changes using optical coherence tomography and ask patients for adequate blood sugar control and more frequent follow-up. This way we can prevent progression to diabetic retinopathy and blindness. Thank you.
Nice, man. But you are told insulin can increase the central macular thickness. I do not know how. Because insulin is supposed to decrease your blood sugar and all.
It was found that when people are taking...
You are telling insulin can increase the central macular thickness. But normally we are giving insulin to diabetic patients to decrease only. You told now decrease the blood sugar can... Blood sugar, if it is less, naturally macular thickness is reduced.
Yes.
How come this insulin can increase the macular thickness in your report?
Patients will be having an uncontrolled blood sugar before taking insulin, maybe because of that.
Insulin increases.
Yes.
So the message you want to convey is for all diabetic patients, OCT has to be done
Yes.
and macular thickness has to be tested.
Yes, ma'am.
Okay. Like at what intervals?
6 month interval.
Once in 6 months. Okay, fine.
No, how did you do sampling?
Convenience sampling was
No,
done.
you took the N as, from some other study.
Yes, sir.
Do you normally do that or you calculate your sampling according to your OPD?
No, we normally do take from another study as an example and do
No, their
some.
numbers could have been 200 per OPD or a number could be 800 OPD, no? So normally that's what you do in your thesis also, no? Based on your OPD and your input only, that is number one. So you have not given any references. Are they in line? No, or your other studies. Are they in line with the other studies or yours is different?
Some studies have.
You are not shown that.
Yes.
You are not shown that. Thank you.
Thanks.
Next we have Dr. Ashita AS. She'll be talking on evaluation of GCA compared to RNFL thickness for the diagnosis of perimetric glaucoma, pre-perimetric glaucoma.
Good morning. I would like to present my paper on evaluation of ganglion cell analysis compared to RNFL thickness for the diagnosis of pre-perimetric glaucoma. OCT has revolutionized the field of glaucoma. Retinal nerve fiber layer or RNFL has become one of the popular and established tool for the pre-perimetric glaucoma diagnosis. Since retinal ganglion cell death precedes the loss of RNFL, by using ganglion cell analysis or GCA, we can detect pre-perimetric glaucoma. So, aim of our study was to compare the diagnostic ability of GCA and RNFL measurements on OCT to diagnose pre-perimetric glaucoma. Our study was cross-sectional and our study population included normal controls, primary open-angle glaucoma and glaucoma suspects. And glaucoma suspects included both disc suspects and ocular hypertension. And our study enrolled 130 patients, which was higher than the minimum sample size. Coming to the inclusion criteria, a best corrector visual acuity of greater than or equal to 6/12 and open angle were common for all the groups. Additional criteria for normal controls include an IOP less than 22, normal optic disc and normal perimetry. For ocular hypertension, it was similar to normal controls except an IOP of greater than 22. For disc suspects, IOP less than 22, disc changes suspicious of glaucoma and normal perimetry. For primary open-angle glaucoma, similar to disc suspects except a perimetry suggestive of glaucoma defined by the Anderson criteria. The exclusion criteria were a BCVA of worse than 6/12, media opacities, secondary cause of glaucoma, retinal diseases, demyelinating diseases, pituitary lesions, and those taking medications like ethambutol. All patients underwent a complete ophthalmologic examination, including best corrected visual acuity, IOP, gonioscopy, and fundus evaluation. Color, optic disc, and red-free RNFL photo were taken. A perimetry was done using 24-2, and after all this, RNFL and GC analysis was done. Coming to the results, our study included a total of 130 patients, out of which 51 were disc suspects, 43 glaucoma, 17 ocular hypertension, and 19 normal controls. The best parameter was chosen by the highest AURSC value. For RNFL parameters, average RNFL was the best parameter in 3 scenarios, such as in differentiating primary open-angle glaucoma from normal, disc suspects from normal, and ocular hypertension from normal. And inferior quadrant RNFL was the best parameter in 2 scenarios, in differentiating disc suspects from glaucoma and ocular hypertension from glaucoma. Coming to the GCA, average GCA was the best parameter in differentiating glaucoma from normal. Inferior GCA was the best parameter in differentiating disc suspects from normal. And infratemporal GCA was the best parameter in 3 scenarios, such as in differentiating ocular hypertension from normal, ocular hypertension from glaucoma, and disc suspects from glaucoma. After obtaining the best parameters in both groups, we compared the best parameters of RNFL and GCA with each other, and we found that GCA outperformed RNFL in 2 scenarios, such as in differentiating glaucoma from normal and glaucoma from ocular hypertension. And RNFL outperformed GCA in 3 scenarios. Those are in differentiating disc suspects from normal and ocular hypertension from normal, and disc suspects from primary open-angle glaucoma with a statistically significant difference. This was the only scenario we got a statistically significant difference. Coming to the literature, Yadav et al. Found that inferior RNFL and inferotemporal GCA were the best parameters and GCA parameters outperformed RNFL parameters. Their final result was against our study. And Deshpande et al. Found that inferior RNFL and inferotemporal GCA are the best parameters and GCA diagnostic abilities were comparable to RNFL. Kaushik et al. Find that average RNFL outperformed average GCA in pre-perimetric glaucoma diagnosis. Even though their results were similar to our study, they only included the average parameters of RNFL and GCA, but we included average along with the thickness in different quadrants. So in our study, it was found that RNFL parameters outperform GCA parameters for the diagnosis of pre-perimetric glaucoma. It may be due to the characteristic distribution of ganglion cell and selective loss of large diameter M ganglion cells. Since the M ganglion cells, which are lost early in glaucoma, are seen outside the macula, the GCA by OCT, which is centered around the macula, may not detect it every time. This may be the reason why RNFL parameters outperform GCA parameters. So it can be concluded that both RNFL and GCA are excellent parameters in the diagnosis of pre-perimetric glaucoma. Though we assume GCA parameters could outperform RNFL parameters in pre-perimetric glaucoma diagnosis, our study didn't establish GCA as a better parameter, most probably due to the selective loss of M ganglion cells. Limitation, our study was cross-sectional, so lacked the advantage and accuracy of a longitudinal progression analysis. These are my references. Thank you.
Good presentation. Can you define pre-perimetric glaucoma?
Pre-perimetric glaucoma is glaucoma when before the perimetric changes occurs. That is, structural changes occurs before the functional changes. That is, patient having both disc and RNFL defects, but it is not evident in the perimetry.
That definition also has to be included because not everybody will know the exact diagnosis. That has to be included.
What would you do to find out the earliest finding? What you look for? You did for.
Yes, sir.
How often do you do perimetry? That's what
For follow-up.
No, to diagnose pre-perimetric glaucoma.
Sir, if we found any RNFL or GCA defects in OCT, we have to follow up the patient in every 3 months. Yes, sir.
That's correct. But what would be the first thing you look for? Is it attraction of field or any specific?
Paracentrism.
Paracentrism. You must be more specific. It's okay.
Okay,
So how did you rule out the pituitary lesions in exclusion criteria? You said no pituitary. I'm happy that you told that when a glaucoma can mimic. How did you rule out pituitary lesions?
Bitemporal effects means chiasmal lesions like bitemporal effects, catastrophic.
Only you diagnosed whether pituitary was there or not. No?
Yes, sir.
Do any imaging?
Sir,
Just asking you, not
no, sir.
because you put it in a criteria and that pituitary lesions there. So you're looking for a bitemporal.
Yes, sir.
Early bitemporal.
Yes, sir.
No imaging.
No, sir.
Thank you, ma'am.
You're told now M cells, M cells of ganglion cell population.
Yes, sir.
How much? What's the percentage of M cells here?
Percentage, I don't know.
Normally, because M cells only constitute 10%.
Sir, most of the ganglion cells are concentrated around the
That is
macula.
okay.
That only I know. I
But
don't know.
usually there are P cells, parvocellular, whereas M cells are only 10%.
10%.
In that study, we can have a frequency doubling technique is there. Why do you want to do this OCT and all? I do not know. To find out the function of M cells, we have got frequency doubling technique is there, so that you can easily find out early.
Yes, sir.
That's also primary perimetric investigations only. Is this superior or you have got any, the instrument is there available in your hospital? Frequency doubling technique, detection, instruments? No.
No, sir. We have only the usual HFM. Yes, sir.
Okay, thank you.
Next, we have Dr. Binuja VA, who will be talking detection of early glaucomatous damage in PXF syndrome by assessment of RNFL thickness and IOP.
Good morning. Detection of early glaucomatous damage in pseudoexfoliation syndrome by assessment of retinal nerve fiber layer and intraocular pressure and observational cross-sectional study. So pseudoexfoliation is a systemic condition. The incidence of pseudoexfoliation increases as age advances. Genetic and environmental factors predispose to pseudoexfoliation syndrome like exposure to UV radiation, climatic condition and proximity to the equator. This study is conducted in the district of Alappuzha, a coastal place where there is an increase in the incidence of pseudo-exfoliation syndrome among elderly. So why I chose this study? Pseudo-exfoliative glaucoma is an independent risk factor for RNFL damage. More than 60% of patients have abnormal RNFL 5 years before the occurrence of visual field defect. Hence, the importance of detection of early glaucomatous damage using RNFL thickness even before visual field defect may help in early diagnosis so that treatment can be started as early as possible. So my objective is to find the relationship between pseudo-exfoliation and retinal nerve fiber layer thickness and the significance in detecting early glaucomatous damage. The secondary objective is to find the relationship between PXF and diurnal variation. So methodology, the patients I used study population of age group 60 years to 80 years attending ophthalmology OPD at tertiary care center. It was a hospital-based observational cross-sectional study and I used non-probability sampling. The study period was 1.5 years. The sample size were 57 eyes. And inclusion criteria, all non-glaucomatous patient who belongs to the age group 60 to 80 years with pseudo-exfoliative syndrome, both bilateral and unilateral. The exclusion criteria include media opacity interfering with visualization and OCT image capturing, history of any ocular surgery or any retinal diseases, those who refuse to give consent, diagnosed case of any type of glaucoma, and other causes of optic atrophy. The study variable include visual acuity, proper slit lamp examination and fundus examination, intraocular pressure with applanation tonometry and diurnal variation, and OCT evaluation using Cirrus ST OCT. Coming to the result and discussion, the demographic variable, that is age, out of 38, 27 belongs to 60 to 69 and the rest 11 belongs to 70 to 79. Even though pseudo-exfoliation relatively common disorder in older individuals in southern India, the increase is multifold. Hence, I chose the elderly age group between 60 to 80 years as my inclusion criteria. Coming to the gender, the female to male ratio were 1:1. Even though some research have said that female preponderance was more, but in my study, out of 38 patients, 19 were female and 19 were male. Coming to the intraocular pressure and diurnal variation, in my study, 19 out of 57 eyes, the IOP was 16 and 16 out of 57 eyes, the IOP was 14 and the mean IOP was 16 mmHg. In my study, there were no significant diurnal variation and the mean variation was 2 mmHg with higher IOP value recorded in the early morning hours and maximum variation of 6 mmHg was seen only in one eye. In the present study, I use Cirrus ST OCT to measure RNFL, and according to study by Apokut et al., the normative data of RNFL was taken among Indian population and I use this as my reference value. The superior RNFL thinning in my study was observed in 22.8%, inferior RNFL thinning was seen in 33.3%, temporal thinning was seen in 35.1%, and nasal thinning was seen in 17.5%, and the mean RNFL was seen in 82.5%. All four quadrants shows a significant RNFL thinning among pseudo-exfoliative patients, and my study shows that patients with pseudo-exfoliation show diffuse RNFL thinning without any specific sectoral involvement. Hence, from my study, it was shown that RNFL thickness assessment using ST-OCT in monitoring optic disc changes of individuals with pseudo-exfoliation can aid in the early detection of patients at risk for glaucoma. To conclude, OCT RNFL assessment with Cirrus ST OCT can be used to assess RNFL changes in pseudo-exfoliative syndrome. There was noticeable RNFL thinning which was diffuse in nature. There were no sex predilection noted. No significant IOP fluctuation was detected among pseudo-exfoliative patients. An early detection of pseudo-exfoliative patient by assessment of RNFL thickness using ST-OCT is essential and should be included in screening method so that treatment can be started to prevent further glaucomatous damage, since pseudo-exfoliation glaucoma has a very rapid and aggressive course. So coming to the limitation, the sample size was less than ideal. The diurnal IOP variation was very difficult because of the nighttime patient was often woken up from sleep, and the majority of the patient has cataract, and that made my OCT very challenging. So these are my references. Thank you.
You admitted all the patients for 24-hour IOP?
We used to keep them in OR, sir. Observation. or we used to that was a problem in my study because majority of them was not ready for screening purpose, but
Can't measure means it should be out of the study.
yes, yeah.
Number one. And number two, you said, what was the problem, another problem in limitation?
That they were often woken up from this sleep. Yeah. Small size, yes, sir.
That only number will reduce.
Yeah.
Or is this only where you could calculate?
No, that because of these things only my samples. Ideally, there was extremely large amount of people who has.
On the incident value.
No.
But generalized.
Yeah.
That is good only, but you have not followed up over a period.
Yes, sir. That is one of the recommendation in my study. I need to follow up this patient more.
Good study.
Thank you, sir.
You are told now the mean value of 16 millimeter mercury.
Yes,
But
sir.
once area you are told 16, other area you are told 14. From
Yeah.
where did you calculate this mean?
Mean I took the average.
Average, then even if you calculate average, it may not be perfectly 16. How can it be? Few cases you have shown 14, man.
Yeah, few cases that is in my out of 38, 57 eyes, two group that is 16 was the most highest value.
That's okay. Some are having 14 also.
Yeah, yes, sir.
Now you calculate everything and divided.
Yes, sir.
Is it 16? Around 16?
Yeah, 16.
Sure.
Yes. Yes, sir.
Definite.
Yes, sir.
Then you told pseudo exfoliation. Is it a correct term or something different?
Exfoliative.
Exfoliation. What is true exfoliation then?
True exfoliation is delamination between superficial layer and deep layer, which is seen in lens surface. It is otherwise observed in glass bowlers. Okay.
Which is the radiation there? Which rays?
Infrared radiation.
Sure.
Yes, sir. Infrared exposure to high infrared radiation was one of the most
How
common.
can they affect a lens, man? Whether it's in between you got IDs and all is there.
In lens, it causes zonule. It can affect the zonules. So
I'm not even asking pseudo exfoliation. I'm asking you true exfoliation.
true exfoliation lens.
How the infrared radiation goes and affect your that lens capsule?
It will.
Yes. For fun, because we want to assess whether you know something or not. For
Okay,
exam
sir.
purpose. You have finished your exams? No.
No, I am going to
Because I
write.
may come as examiner.
Your thesis presentation,
Yes, sir. This way.
you are allowed to present before your exam.
Yes, sir. I have already published in case.
No, because
Published also.
I mean, we are already submitted. Yeah.
Accepted.
It is coming in one or two. MS.
because we may come as examiner for you. So something questions are released now. You tell me how that infrared affects your lens.
Okay, so that mechanism correctly.
See, it is absorbed by the pigment epithelium of the iris and the heat is liberated, that's all.
Okay, sir.
Okay,
Okay.
thank you.
Thank you, sir. Thank you.
Very expressive presentation.
Thank you.
Okay. And what is the normal RNFL thickness?
Normal RNFL, it is around a range of 103 to 105 in superior and in inferior. But in nasal and temporal, it is normally is around 93 and 80. I mean, nasal, it is.
So whenever you are talking about abnormal things,
Yeah.
you have to show normal also.
Oh,
You can
yes.
compare and
Okay.
we are learning for the audience.
Sure, ma'am. Sure. Thank you.
Next, we have Dr. Swaroop KS, who will be talking on knowledge, attitude and practice patterns regarding medical legal aspects among cataract surgery patients.
In so many, about 20 presentations, he is the first boy. Welcome, man.
Thank you, sir.
One boy.
So, good morning, all. The topic for my paper is knowledge, attitude, and practice pattern regarding medical legal aspects among cataract surgery patients. These are my contents. As we all know, medical legal aspects have gained significant attention in the last few years. There have been about 5.2 million cases of medical error filed in India every year, and the number has increased by around 400% in the last decade. But the knowledge, attitude, and practice regarding this topic remain poorly understood, and cataract surgeries are often advised as no pain, no stitch procedures that can be performed on a daycare basis with immediate vision gain. This increases patients' expectations regarding the outcome, making ophthalmologists more vulnerable to such litigations. So my objective was to estimate the knowledge, attitude, and practice pattern regarding medical legal aspects among cataract surgery patients. And it was a hospital-based descriptive study conducted among patients posted for cataract surgery. We did it among 52 patients after obtaining their informed written consent. The patient demographics and information about prior history of surgery was collected, and the questionnaire had 3 parts. As you can see, it had the knowledge, attitude, and practice with 5 questions each. Knowledge was based on the prior knowledge the patient had regarding the importance and need for informed consent and other medical legal aspects. Attitude was regarding the attitude towards the need for knowing about the treatment and complications, and other aspects like patient's rights, responsibilities, and responsible behavior towards health workers. Practice was based on what the patient had done regarding consent, patient's rights and responsibilities following his or her admission in our department, and scores were given based on their responses, and they were classified as having poor, average, and good knowledge, attitude, and practice. Statistical analysis was conducted using the SPSS software, and these were the results. As you can see, the mean age was 66.9 plus or minus 9.4 years, and majority of them, that is 65% of them, were females. 83% were below the poverty level, and 52% had prior history of surgery. In the education levels, we can see majority of them, that is around 60%, had finished their primary education, and only 8% were illiterate. Now coming to the knowledge patterns, good knowledge pattern was seen in 21%, average was seen in 48%, and poor knowledge was seen in 31%. The highest knowledge was for the question regarding the legal importance of informed written consent, and the lowest was for the question regarding the patient's right to withdraw the consent if required after signing it. Statistically significant relationships were found between knowledge level and education, as well as knowledge level and age. Attitude results were promising, as 81% showed good attitude and only 19% showed average attitude. The highest attitude level was for the question regarding the patient's responsibility to maintain decorum within the hospital, and the lowest attitude was for the patient reading through the patient responsibility guidelines given by the hospital. Statistically significant relationships were also found between attitude and education level, as well as attitude and prior history of surgery. Practice levels were concerning, as only 2% showed good practice patterns, 52% showed poor practice patterns, and 46% showed average practice patterns. The highest practice pattern was for the question regarding the patient inquiring about the treatment options available with the doctor, and the lowest was for the patient reading through the rights and responsibilities displayed in the hospital. Statistically significant relationships were found between practice level and age, practice level and education, as well as practice level and history of surgery. As you can see in the scatter plot, there was a moderate positive correlation between knowledge and attitude, a strong positive correlation between knowledge and practice, as well as a strong positive correlation between attitude and practice. So in my study, the knowledge was found to be good in 21.2, average in 48.1, and poor in 31.2%, which was similar to the results obtained by Garima Kachava et al. 92.3% of our participants knew that informed consent was of legal importance, which was much better than the results obtained by Sanjay Marasani et al. It was concerning to note that 53.8% believed that they could not withdraw their consent after signing it, and similar results were obtained in the study conducted by Rajesh Dr et al. This study also showed a positive association between level of education and knowledge, as was seen in our study. Despite the average levels of knowledge, 80.8% of our participants showed a good attitude, and the results were much better than those obtained by Felix Ambonera et al. The same study by Felix Ambonera et al. Showed a positive correlation between knowledge and attitude similar to our study. And despite the average knowledge and good attitude in majority of our subjects, practice assessment results were concerning, as only 1.9% demonstrated good practice. This might be the reason for the increase in violence and unnecessary allegations against doctors, as highlighted by the 2015 survey by the Indian Medical Association, finding that 75% of doctors have faced some form of violence at work. So my suggestions include using visual aids, informative videos, simplified languages, and repeated explanations, as suggested by the work of Abrar Karan et al. As well as Anita and Shukla et al. Awareness programs can be conducted, and medical legal aspects can be made a part of the curriculum for UGs and PGs with emphasis on practical applications. The limitations of my study include: the study can be conducted with a larger sample size, it can be conducted among the general public as well as the medical staff to assess their awareness about this topic. To conclude, my study highlights the interconnected nature of knowledge, attitude, and practice in context of medical legal aspects of cataract surgery. Although Kerala boasts the highest literacy rate in India, despite having good knowledge and good average knowledge and good attitude in majority of our patients, the practice patterns were concerning, as only 1.9% showed good practice. Our study also shows the influence of socio-demographic factors on this context, hence providing practical awareness regarding medico-legal aspects at the grassroots levels is essential in bringing about a change in the society. These are my references. Thank you.
Old study, okay. What do you think will, if you start implementing in your hospital,
Yes.
what will happen to your practice in your hospital?
Sir, our practice has always remained the same.
No.
But
Now
it's
we have created this thing, one study. If you start implementing for every patient, every surgery patient, what will happen?
sir, I think as we saw in this, the knowledge was average
So
and
litigations will go against your hospital, numbers will go. You agree? You are creating an awareness. There is no
Yes, sir.
doubt about it. That is good. Actually, it's good to do that. But why did you say consents cannot be retrieved back, cannot be withdrawn?
no, it can be withdrawn. Like the patients were not aware that.
It's the patient's consent, no?
Yes,
Even
sir.
in the last minute after sign-in, before time out, you know what is time out? Before putting the incision, he can walk out.
Yes,
He
sir.
can say that is there. Number 3, if you had done the study for doctors, no, regarding awareness of medical legal cases,
Yes,
I
sir.
would have given you 100 out of 100. Because the awareness of doctors is only bad, but this is also a very bold study.
Yes.
Second thing is what I would like to tell everybody. You are writing the words continuously like sentences and reading. Put bullets and talk. That will be more from the heart rather than reading. Good one.
Sir, one thing regarding the studies conducted among doctors, I searched the literature and previous studies have been conducted regarding the awareness among doctors, but among patients till now, especially in under ophthalmology, no study have been conducted.
Spite of all that, no, doctors
Yes, sir.
even do not know what is the grievous injury. Want to put AR entry. If it is already put AR anywhere, no, that's just lacking now, especially with NAB it's coming in. But that element, not that data. This is a new
Yes.
one. So we are increasing the awareness to increase the 400% will become 800% the next decade. Definitely. Because if they know that I have had a complication, the lawyer will come and see me and say, you give me 50% of the claim, I don't give me any fees, I will work and get you money. That is what is happening now. Anyway, good.
Nice presentation, doctor. But
Thank you.
I think in future, I don't think doctors will practice. I think.
It's a good presentation and a different
you, ma'am.
presentation. That's what we've been telling since yesterday. So it should not be regular, like we are seeing a lot of OCT and retina. So this is completely different. I appreciate.
Thank you, ma'am.
Next, we have OCTA, vascular changes in macula following cataract surgery.
The award will go to actually the OCT machine, sir. 50% are OCT.
Becoming OCT specialist.
By Dr. Aishwarya Xavier. Yeah.
So the topic is OCTA, vascular changes in macula following cataract surgery. Cataract is an avoidable cause of global blindness that can be effectively treated with cataract surgery. It is essential that we know the changes in capillary circulation at fovea after an uncomplicated cataract surgery, as it can predict macular ischemia and thereby postoperative visual prognosis. OCTA represents a reliable non-invasive tool for detecting retinal blood flow parameters with high degree of repeatability. The aim of my study is to estimate the change in the vessel density, perfusion density, and foveal avascular zone before and after uncomplicated cataract surgery, and also to compare the same among diabetics and non-diabetics. It was a cross-sectional study done from September 1, 2022 to August 31, 2023 at Believers Hospital, Tiruvalla. A total of 32 non-diabetics and 31 diabetics was included in the study, and all of them had an uncomplicated cataract surgery with posterior chamber IOL implantation. We excluded patients with intraocular pressure more than 21 mm of mercury and with history of ocular trauma or intraocular surgery, or with any retinopathies other than mild diabetic retinopathy, or with any history of previous lasers to the macula, or poor OCT images, unstable fixation, intraoperative or postoperative complications with OCT angiography signal strength less than 5. All participants underwent routine examinations prior to cataract surgery, and OCTA scans was taken preoperatively at any time before surgery and postoperatively at 3 weeks, 6 weeks, and 3 months. OCT parameters like vessel density, perfusion density of the central, inner, outer, and full area, as well as foveal avascular zone area, perimeter, and circularity index in the superficial capillary plexus of all participants was evaluated preoperatively and postoperatively. The comparison of all these parameters between diabetics and non-diabetics and the rate of change of these parameters over time between the two groups was done with generalized linear regression model. A total of 63 patients was studied and 32 was non-diabetics and 31 was diabetics. Among the diabetics, 21 had non-diabetic retinopathy and 4 had mild non-proliferative diabetic retinopathy. So this is a vessel density graph in diabetes and non-diabetics. The red bar denotes diabetes and the blue one denotes non-diabetics. And we see that vascular density was higher among non-diabetics when compared to the diabetics. And there was post-operatively increase in the vessel density in both the groups equally at 3 weeks post-op visit. And it remained almost the same at 6 weeks and 3 months. Similar findings was also noted in the perfusion density in diabetics and non-diabetics. And coming to the FAZ, the FAZ of the non-diabetics was lower than the diabetics, and post-operatively there was a decrease in the FAZ area, perimeter and circularity index, and there was significant decrease in the perimeter and the circularity index at 3 weeks of post-op, and then it remained almost the same. So coming to the discussion, almost all of the other studies was synonymous with our study, and it also showed an increase in the vessel density and perfusion density and a decrease in the foveal avascular zone area changes. A decrease in the intraocular pressure, post-operative inflammation and an increase in the light exposure was reported to be the reasons for the increase in the vessel density and perfusion density post-operatively. But some studies denied the role of decrease in IOP and post-operative inflammation and upheld the light exposure to be the primary cause for the increase in the vessel density and perfusion density post-operatively. So coming to the conclusion, there was a significant increase in the vessel density and perfusion density and a significant decrease in the FAZ perimeter and circularity index in diabetics and non-diabetics post-operatively from the preoperative value. The exact cause for the increase in the vessel density and perfusion density following cataract surgery is unknown and is a scope for future research. And the macula, which is compromised in diabetic retinopathy, shows an increase in the vessel density and perfusion density following cataract surgery. Whether these changes are only transient and what effect they will have clinically need to be studied further. So these are my references. Thank you.
Any reason for this foveal avascular zone decrease in size after cataract surgery?
They say that there is...
Because you are told something for other things, other parameters. But avascular zone decrease, how can it happen after cataract surgery? In what way is related?
They say that there is an increase in the vascularity following cataract surgery due to changes like increase in inflammation and light exposure. So,
That's for what density and all you are told.
yeah.
What about avascular zone? That's why zone is increasing. Vessels are growing now.
Because of the vascularity itself, the zone is getting decreased in its size. Thank you, sir.
Dr. Parvati S. Nair, speaking on evaluation of 250 patients with OCT screening of retinal pathology prior to cataract surgery.
Good morning, everyone. I am going to present a paper on evaluation of 250 patients with optical coherence tomography for screening of retinal pathologies prior to cataract surgery. So cataract is one of the most common causes for visual loss in adults, and cataract surgeries are the most commonly done ophthalmic surgeries around the world. So routinely, a fundus examination is performed before a cataract surgery by biomicroscopic fundoscopy, but subtle macular pathologies may be missed, which can be a cause of postoperative low vision. And these subtle pathologies can be easily picked up by an imaging technique, that is a spectral domain optical coherence tomography, which allows for a detailed cross-section of the macular region in the presence of a media opacity like that of a cataract, or in case of non-dilating pupil. As the OCT has a potential to improve the preoperative diagnostics in patient prior to cataract surgery, with considerable impact on further therapy. So aim of our study was to assess the screening benefit of the spectral domain OCT as a part of routine preoperative evaluation in cataract surgery to detect any macular pathology. It was a retrospective study in conducted in patients who underwent cataract surgery at a tertiary eye care center, and 250 eyes of patients were selected. And the study period was 6 months, and the data was collected from the electronic medical records of patients, which included the patient's age, gender, systemic status, the grade of the cataract, and the preoperative spectral domain optical coherence tomography, 3x3 volume scan, the line scan centered to the fovea on Hilberg spectralis. We included patients with significant cataract haze with an apparently normal fundus on indirect ophthalmoscope, on an exclusion criteria in mature cataract, and patients who were already on follow-up for any retinal pathologies. Coming to the results, the age of the study participants ranged between 29 to 85 years, with a median age at 70 years. And most of the patients had nuclear sclerosis cataract, followed by posterior capsular cataract, and followed by cortical cataract. And among the 250 eyes, we could see an OCT abnormality in about 68 eyes, that is about 27% of the patients. And the different OCT abnormalities included, most commonly it was drusense, followed by vitreomacular traction about 11%, and 8.8% of epiretinal membrane, vitreomacular adhesions, and about 4.4% of posterior vitreous detachment. And 25% patients had other findings, which included pigment epithelial detachment, foveal contour flattening, retinal pigment epithelial changes, and microaneurysms. So these are the subfoveal drusense. There's an epiretinal membrane with a pseudo hole. It's a vitreomacular traction with an intraretinal cyst, and this is a posterior vitreous detachment with a foveal contour alteration, which can now result in a reduced post-op visual acuity. And the post-op visual acuity in patients with the OCT abnormality, we could see that the visual acuity improved to 6.6 in about 58.8% of patients, but visual acuity remained less than 6.6 in about 41% of patients, and among the 41%, the visual acuity improved to 6.9 in 78% of patients, about to 6.12 in 7% of patients, and about 14% of patients had a visual acuity of 6.18 post-operatively. The OCT abnormalities with visual acuity less than 6.6, most common again was drusense, followed by vitreomacular traction, then vitreomacular adhesions, epiretinal membrane, and posterior vitreous detachment. In 41% patients with post-op visual acuity less than 6, and active intervention was taken for about 15% of patients, and among them 10% underwent vitreoretinal surgery for epiretinal membrane and vitreomacular traction. Coming to the discussion, our study included 250 eyes, and about 27% of them had OCT abnormalities, with drusense, that is age-related macular degeneration, being the most common, followed by vitreomacular traction, followed by epiretinal membrane, which was similar to all studies like Carbacos et al., Morira et al., and Klein et al. And they all concluded that optical coherence tomography was more effective than indirect ophthalmoscope to detect subtle macular pathologies. To conclude, the preoperative OCT was able to detect subtle macular pathologies which remain undiagnosed during a routine dilated retinal evaluation. An active intervention was taken for about 15% of patients with OCT abnormality, and we could explain guarded visual prognosis to a higher percentage of patients. The progression and stability of the pre-existent retinal pathology was able to be monitored, and we were able to make the patient aware of the visual prognosis to overcome any possible litigation or unhappiness to the patient. So the suggestion that we put forward was preoperative optical coherence tomography screening can be performed prior to cataract surgery to enhance the patient's visual prognosis. These are my references. Thank you.
Very good slides. Actually, we have been telling this since yesterday again. The slides have to be better. It has to be in brighter colors. And yeah, this was a really good presentation. And all these can be almost clinically found, right? Why do you need OCT?
In patients with significant cataract haze, indirect ophthalmoscopy will be difficult to see the fovea and the macular region.
Okay.
So OCT can detect these macular pathologies which can be missed in
But you have
significant
excluded mature cataract. So
Yes.
you mean to say like brown cataract?
NS3,
3 to 4,
NS4,
NS3 to
PSC
4.
cataract.
Okay. And do you know how much does OCT cost for a patient?
2000.
Is it so?
1000.
You should know when you're doing a study, because the cost factors are also important, because you are doing too many investigations for the patient, basic blood investigations, A scan, and so many things are there. So that cost factor also has to be considered. Okay. Only 15% needed active intervention, right?
Yeah,
So is it worth doing OCT for all the patients? That is my question.
we were able to make the patient be aware of the retinal pathology in case the
For
visual
our own
acuity-
safety, right? Okay, good.
No, very good only. Actually,
Good.
the idea is good. But you remember, no, 60-70% of the cases are camp and free. So can afford. Hospital can manage. Basically, the cost is nothing. So that is good, fantastic study. But you mean to say majority of the drusen were not clinically detectable?
No, it was detectable, but we could differentiate the drusen's
Many
which could affect the visual
only for premium IOLs, multifocal, toric, they do it as a routine because expectations are high and it charge 1 lakh, 2 lakh and so on.
Yes.
That's okay. Another thing, you said commonest ophthalmic surgery in the world is cataract. Correct or wrong? Anybody? Commonest surgery in the world done on the human body, not only ophthalmic. Okay, commonest, we do 17-18 lakhs in India alone. Good man.
Thank you.
Dr. Sharanya MS. The topic is knowledge, attitude, and practice of postoperative care in cataract surgery patients.
Good morning all. I will be presenting my paper titled Knowledge, Attitude and Practice of Postoperative Care in Cataract Surgery Patients. Aim of my study was to estimate knowledge, attitude and practice pattern of postoperative care in cataract surgery patients in a secondary care center. It's a cross-sectional study conducted using a structured questionnaire among 54 post-cataract surgery patients in a district hospital, Kerala. Section A contained demographic details. Section B contained 10 questions regarding knowledge. Section C contained 6 questions regarding attitude, and Section D contained 6 questions regarding practice, and knowledge, attitude and practice were scored into good, average and poor according to the patient responses. 76% patients were from urban areas, 85% patients were married, 53% patients were unemployed, and 77% patients living in nuclear families. The mean age was 64.57 years, ranging between 51 to 93 years of age, and majority of patients are between 51 to 60 years of age. 52% were females, 41% had primary level of education, and 28% had non-formal education. 50% belonged to low socioeconomic status, and 48% were belonged to middle socioeconomic status, and 59% had diabetes mellitus, and 42% had systemic hypertension. These were the responses to knowledge questions. 83% were aware that they cannot lie on operated side, and all the patients were aware to wear protective eyeglasses during daytime. But only 22% were aware that they should use an eye shield at night to protect eyes. And 90% of patients aware to report to ophthalmologist if they have any post-operative symptoms, and 92% of patients aware about the proper technique of cleaning of eyes after surgery, and 66% of patients aware the tip of eye medication bottle should not touch any area of eye. The overall responses to knowledge is good in 75.9% and average in 18.5%. These were the responses to attitude questions. 85% of patients thought it's necessary to perform hand hygiene before putting eye drops, and 77% of patients thought complete bed rest is needed after cataract surgery. And only 5.55% patients thought it's necessary to use an eye shield for protecting eyes while sleeping, and only 14.81% thought the right direction of cleaning eyes is from inner to outer canthus, and 57.4% of patients
thought it's necessary to visit an ophthalmologist when they notice persistent pain and redness of operated eye. The overall responses to attitude is good only in 9.2%, average in 55.5%, and poor in 35.18%. These were the responses to practice questions. 18.5% using an eye shield to protect while sleeping, and 44% washing hands before instilling eye drops, and 79% using protective eyeglasses during daytime. And 46.2% cleaning the operated eye with lukewarm water, and 18.5% sleeping on the same side of operated eye after surgery, and 59% always following the post-operative instructions provided by healthcare worker. And the overall responses to practice is good only in 5.5% and average in 75.9%. There is no statistically significant correlation was found between knowledge, attitude, and practice scores. In our study, knowledge was found to be good in 75.9%, average in 18.5%, and poor in 5.5%. Similar results were seen in a study conducted by Sharma and et al. Among 115 patients. While 85.1% of patients in our study recognized the importance of hand hygiene before eye drop administration, only 44.4% actually practiced it. This contradicts with the Shellac-Jacqueline Smith study, which reported 100% knowledge and 75% practice. And our study found that 66.6% of patients had adequate knowledge about correctly instilling eye drops. It was much higher than a study conducted by Lieutenant Colonel Shweta Prasad et al. And our study found that all patients knew the importance of wearing protective eyeglasses during daytime. And only 22.2% knew that eye shield should be used for protecting eyes during nighttime. It was much lower than a study conducted by Minirani et al. And in our study, 90.8% of patients were aware on the importance of seeking doctor's advice after surgery when they have any post-operative symptoms. Now, almost similar results were obtained by a study conducted by Minirani et al. Kerala being a state with high literacy rate, majority of patients had good knowledge, but attitude and practice were only average. This shows the need of educating patients and caregivers regarding the importance of post-operative eye care. Emphasis should also be given on the importance of adhering to post-operative instructions and attending follow-up visits. We can also provide resources like post-operative kit with instructions for ensuring better patient compliance. These were my references, and thank you.
Good presentation. It was again different. How do you think you can make the patients follow all your post-operative instructions? Not only post-operative instructions, generally whatever advice we give for the patients, most of the patients do not follow. How do you think you can make them follow? It's a simple question.
During each post-op visit, we can give instructions repeatedly.
Yeah, we give instructions. That is our duty, and we do lots and lots. But how will you make them follow it?
We can also provide post-operative kit free of cost.
Anything else? See, always explain the consequences. If it is not done, what will happen to the patient? Okay. If drops is not applied properly, if the hygiene is not maintained properly, what will happen? What will be the consequence? Okay, then you can make them follow, because that is the main point of your study, right? That is the message you want to convey to the society, right? See, for every paper and every study, there should be a message to the society. So that is the message. If you want, they are not following properly. So if you want to make them follow, you explain the consequences in a good way. Okay? Good.
Sir, this is 1 week, 2 week, 3 week, and 4 weeks after. Same patients. Average.
The counseling was done at the
first post.
So you are from district hospital?
Yes, sir.
This is the first time I have seen.
Sir, I am in DRP program, district residency at that time.
So you are finished DNP or not?
No, sir, I am an MS student.
MS.
I am just second year completed.
Studying in college?
Yes, this study in DRP, I was in DRP.
You have done in district hospital when you were deputed there?
Yes, sir.
Okay.
3 months posting was there.
You told free drugs can be given. How can it be, man? I don't think in the government you can give free drugs.
Sir, under CASP we can give drugs free of cost.
CASP? What is that?
That's Prime Minister's insurance scheme, we can say. Yes.
What all you give?
Under this, we can give eye drops, eye shield. We can also give wet wipes.
Right.
Drugs we are giving prednisolone, steroids, moxifloxacin, flurbiprofen, and CMC. All we can give all drugs.
Moxie for how many days?
3 weeks.
Correct or wrong? Think it over, okay? It is not with a mark or anything, but Moxie for 3 weeks. Okay. Thank you, ma'am.
Thank you, sir.
Good study.
Thanks.
The next speaker is Dr. Archa SS, and the topic is treatment outcomes of intermittent divergent squint in pediatric age group.
Good morning. My topic is treatment outcomes of intermittent divergent squint in pediatric age group. Intermittent divergent squint is intermittent exodeviation of eyes. The prevalence is between 0.1% and 3.7% in children. There are basic intermittent exotropia, divergence excess, convergence insufficiency, simulated or pseudo-divergence excess. The indications of treatment are increasing the frequency of manifest phase of squint, gradual loss of functional control, increase in size of basic deviation, and wide stereo acuity. The various treatment strategies include glasses and overcorrective minus lens, Brock's ring, pencil push-up, cat card exercise, patching, and squint surgery. The aim to assess the outcome after various surgical or non-surgical method in restoring ocular alignment and achieving binocular single vision. The materials and method. This is a prospective observational study conducted from June 22 to September 2023. The sample size is 73 children and the age group is in pediatric population. The parameters are visual acuity, cycloplegic refraction, orthoptic examination, which include motor and sensory examination, ocular motility test, fundus examination. We have done follow-up in 3 and 6 months. Newcastle scoring in intermittent divergent squint. It is based on home control and office control. Home control is based on the history given by the parents. Total score is score of home control, score of clinical control, distance, and the near. Coming to the results. 45.2% of the children included in 3 to 6 years, and females are most commonly affected in our study group. 82.2% were a basic type of intermittent divergent squint followed by convergence insufficiency. Treatment. 42.5% received patching treatment. A quarter of the patient, 26%, underwent surgical treatment. Rest of the patient underwent convergence exercise, glass and overcorrective minus lens treatment. Comparison of stereopsis in various treatment modalities. Even though all treatment could achieve a good stereopsis, patching group experienced a significant functional improvement. P-value was significant. Treatment and angle of deviation, PBCT distance. The surgical group experienced a good improvement after surgery. P-value was noted to be significant. Similar in PBCT near, the surgical group experiences good functional improvement. Newcastle score at the time of presentation. We assessed Newcastle at the initial visit and noted that with surgery done in Newcastle score of more than 4. The amblyopia and stereopsis. In our study group, 10.8 patients were amblyopic. None of the patients' stereo acuity improved in amblyopia compared to non-amblyopic. Coming to discussion. Our result. Basic type was the most prevalent intermittent exotropia in our study group. Similar study by Burian and Spivey reported that 65% of the patients had basic in their study population. Convergence exercises like cat card exercises, pencil push-up exercises could achieve a significant reduction in stereopsis in our study group. Similar study by Song et al. Found that pencil push-up training and part-time patching had similar therapeutic efficiency in improving distance deviation. We assessed Newcastle score at the initial visit for every patient and noted that the score more than 4 underwent surgical treatment in our study population. Similar study by Holmes J. M. et al. Surgery is typically recommended if Newcastle score is equal to or greater than 4 or it deteriorates over time. Our results show a decrease in total deviation both for near as well as distance after patching for a period of 6 months. Study by Bang et al. Also showed that objective measurements of near and distance exotropia decreases after patching of the fixating eye. Stereo acuity not improved in amblyopia in our study. Similar study by Wallace et al. So the take home message is early intervention is necessary to achieve good motor and functional outcome in intermittent divergent squint. Here come the importance of school screening and parent education needed for early intervention and treatment of intermittent divergent squint and achieving good motor and sensory outcome. Thus also play a role in psychosocial life of the children. These are my references. Thank you.
You advised convergence exercise, no?
Yes, sir.
What type of exercise have you given?
We give pencil push-up training, cat card exercises mainly.
You are not using prisms and all.
No, sir.
You didn't use prisms to improve the.
Not commonly used, sir.
Yes. You know how to use the prisms and all? You know how to use prisms?
So exotropia we give base in prism.
Basin for correcting. For exercise?
Not sure, sir.
Yeah, opposite, that's all. See, exotropia I told.
Yes, sir.
Basin. So we exercise base out. That's all.
Okay.
Okay.
Yes, your slides were good and I like the animations.
Okay, thank you.
It was different.
One advice is you put a light green bar.
Okay.
Don't put a white color font.
Okay.
Put a dark black color. Of course, dark green with white is good. Light green, light to white. No, here it is coming clearly, but there no, it is not that clear. The contrast should be absolutely opposite.
Okay. Thank you, sir.
Next, we have Dr. Shine NS, who will be talking on OCTA as a diagnostic tool in intermediate and posterior uveitis, a clinical and imaging study.
Good morning all. My topic for paper presentation is assessment of optical coherence tomography angiography features in uveitis. OCTA, otherwise called as OCTA, it utilizes advances in OCT technology. It gives us high resolution angiographic information in a non-invasive, non-dye method correlated with the OCT B scans. Aim of our study is to assess the OCTA features in uveitis, enhancing the diagnostic accuracy and understanding various intermediate and posterior uveitis conditions. It was a prospective observational descriptive study which was done in patients diagnosed with intermediate and posterior uveitis. It was done for 18 months and in 84 eyes. We included patients diagnosed with intermediate and posterior uveitis and patients aged 10 years and above. We excluded patients with weak OCTA signals due to corneal and lens opacities and with other retinal pathologies. All the patients undergone complete ophthalmological examination and diagnosis of posterior or intermediate uveitis made, and laboratory radiological investigations were conducted as needed. All patients undergone OCTA imaging acquired using Heidelberg Spectralis OCTA system on presentation and follow-up. This is an interface showing Heidelberg Spectralis OCTA. We can divide the layers by layer: superficial vascular complex, deep vascular complex, and avascular complex, and choriocapillaries and choroid. Automatic segmentation. Also, we can do manual segmentation. Coming to result, the main disease type we encountered in our study was BKH, and followed by toxoretinochoroiditis and serpiginous choroiditis. The findings in superficial capillary plexus was less, and we could find out a significant amount of artifacts in this layer. In deep capillary plexus layer, flow deficit area was the main feature. In outer retina, we could find out neovascularization and CMVM almost 4% of patients. This is image of CNVM in OCTA interface. In choriocapillary layer, the flow void areas was the main finding. This is an image of flow void areas in a choriocapillary layering in OCTA imaging. In choroid also, flow void areas was the main findings.
we could find out almost 12% of artifacts in these eyes. It was increasing from deeper to superficial layers. And also we could note the change of area by subsequent OCTA, and the main finding of flawoid areas was decreased in subsequent follow-up. It was decreased in 42% of patients, and it was correlating with the best corrected visual acuity in patients, which was improved with the improvement in the area. And we could find out neovascularization and CNVM in follow-up visit in patients before the symptoms appear. And further similar studies were done which revealed correlation between microvascular changes and clinical parameters, which aiding in the early diagnosis and management of uveitis. Similar studies by Melachuri et al., Dinkerkus et al., and Tranospi et al. Showed lesions in superficial capillary and deep capillary plexus detected by OCTA. Deep capillary plexus findings was more than superficial capillary plexus, and also superficial capillary plexus had higher number of artifacts in these studies also. In Herbert et al. And Tranospi et al., the avascular complex layer also got almost 17% of changes, and also similar to their study, we were able to detect neovascularization CNVM in these layers. In multiple studies showed choriocapillary and choroid layer have flow void areas as the main findings, which was similar to our study. A limitation to our study is we only use qualitative assessment with the OCTA, and not every patient had follow-up with the OCTA imaging, and acute conditions had more segmentation errors and poor image quality, and there was a lack of comparison with other imaging modalities like FFA, ICGA, and OCTA does not detect vascular leakage, which was important for inflammatory vasculopathy. To conclude, OCTA effectively identified various pathological changes in retinal and choroidal vasculature, including the various layers, and the significant association between these changes and uveitis highlight the potential of OCTA as a diagnostic and monitoring tool. We recommend OCTA as an adjunctive tool with along with the fundus imaging, FFA, ICGA, to objectively evaluate inflammatory status of the uveitic eyes. So, and presence of artifacts in OCTA images necessitate the careful interpretation to avoid misdiagnosis. Also, we should have training and experience in OCTA interpretation for a crucial accurate assessment. These are my references. Thank you.
It was a good study first time we are seeing in uveitis, I think. Is it practically possible?
Yes, madam. Because it's a non-invasive, we are not using a dye. Multiple FFA or ICGA episode we could avoid, and also if we are the financial constraint, if it's not there, we can use it for multiple imaging for follow-up mainly.
But follow-up means again every time you have to keep on doing, right? So
no,
will not that be a burden for the patient?
If we find out any changes in fundus examination or any symptoms, early symptoms, we could pick up early CNVM or neovascularization is layer by layer without dye injections in these patients. Okay. So it will be useful for patient having any contraindication for dye injections, madam.
Okay, right.
If there is no improvement in spite of treatment, then it will.
Yes, ma'am.
Was there any past planages in your study?
There was 10% of patients was there, but there was
without any etiology? No,
etiologies was there, intermediate was there, but OCTA findings were very less, because if there was a neovascularization into the vitreous, we could find out.
The double component, posterior and
intermediate.
So relatively posterior uveitis
more findings and intermediate. If they had a neovascularization coming into the vitreous, we could find out. Otherwise, less findings was there.
So even pars planatis, they will manifest as macular edema. The most common cause for visual loss in pars planatis is macular edema.
Yes.
They will come to you.
If there is edema, the acute conditions, if there is higher edema and distortion of inner layers, there will be segmentation errors and the artifacts more in the superficial layers.
You can
So
get it with your OCT only.
Oh, yes, sir.
May not do.
Oh, yes.
Thank you.
Okay, thank you.
Next, we have Dr. Nice O, who will be talking on clinical relevance of the new 24-2C HFA grid to conventional 24-2 in glaucoma practice.
Good morning. Topic of presentation is clinical relevance of the 24-2C pattern in Amphifield analyzer compared to the conventional C24-2 in glaucoma practice. 24-2C See the Faster is a new testing paradigm in HFA3. Daily routine, it is a still underutilized tool. It incorporates additional 10 points in the cent degree around the fixation when compared to the conventional C25-2 See the standard, and it has the potential to detect early visual field defects. Aim of the study is to compare the visual field parameters between the newer 24-2C See the Faster versus the 24-2 See the standard, and also to analyze the structure versus functional correlation between the spectral domain OCT indices and the perimetric global indices. Our study is a prospective cross-sectional observation study of duration 1 year with 50 patients enrolled from the glaucoma clinic of a single consultant. And we included primary open-angle glaucoma and normal tension glaucoma, and patients those with secondary glaucoma and significant media opacity were excluded. And the 50 patients were stratified into Group A and Group B. Group A is comprises of iris glaucoma suspects with normal visual field in See the standard, and Group B comprising the early manifest glaucoma with disc changes correlating with the early visual field defects in See the standard. And we analyze the visual field parameters including reliability indices, mean test duration, 4-wheel threshold, glaucoma hemifield test, global indices. And the overall global indices is compared with the spectral domain OCT indices, average RNFL thickness, sectoral RNFL thickness, and average GCL thickness and sectoral GCL thickness. Majority were males, and age-wise the suspect were in above 70 years and manifest were in between 50 to 16 years. The most important outcome in our study was the 50% reduction in the mean test duration on the newer pattern See the Faster when compared to the See the standard in both groups, and which means we pick up an extra early glaucoma patient with the newer test pattern. This table shows that in glaucoma hemifield test when with See the standard, out of 25 patients, 23 were within normal limit and 2 were borderline, while in See the Faster, 22 were within normal limit and 3 were borderline. We show we pick up an extra early glaucoma patient, and this is the field. You can note the early central defect in 24-2 See the Faster, while See the standard is within normal limit. And these are the fields in Group B patient with early glaucoma noted that only the peripheral defects early peripheral defects picked up by the both conventional and the newer strategies. And the Group B patient with central defect on See the standard and cluster of central defects on the newer See the Faster. So, newer pattern probably replaced the conventional in clinical practice. Other visual field parameters were comparable between the two strategies but not significant except the visual field indices in Group A. Coming to the structure functional correlation, only the mean deviation showed a positive correlation to the average RNFL thickness. Coming to discussion, 24-2C showed a shorter testing time in all the published studies, and our result of 50% reduction See the standard when compared to the See the standard is thus comparable. And other parameters like visual field parameters are comparable in all studies but not significant. Finally, the structure functional correlation publication have been more with 30-2 and OCT RNFL indices, and all showed a positive correlation between the mean deviation and average RNFL thickness, which is similar to our study. So to conclude, Amphi grid pattern 24-2C on See the Faster in comparison to the conventional C24-2 See the standard strategy provide a benefit in test time with comparable visual field performance. And average RNFL thickness in manifest glaucoma patient positively correlated with the mean deviation global indices on the Amphi See the standard and See the Faster strategy. So, early glaucoma detection with the newer grid 24-2C is a possibility and can be judicially integrated into clinical practice. These are my references. Thank you.
It's a good presentation. So first slide, you have to tell what is the difference between your CETA standard and CETA faster, because you are comparing two studies, right? Means two modalities. So you tell us what is the difference.
Yes.
Yeah, can you show it again? And what is the duration of both the tests? Have you mentioned it there?
When compared to the test time.
Time. The duration of the test, because you are saying this is faster.
Yeah.
So how faster it is?
50%. That is 2 minutes.
No, I'm just
2 minutes in CETA faster and 4 minutes in CETA standard.
That and all you have to mention. So then only everybody will understand. Can you show that slide which compares?
No, CETA faster is introduced in 2019. So here we can see that the additional 10 extra points in the central 10 degree.
Yeah, you have to use a pointer and tell us.
This is a CETA standard program, and I added the 10 more points in the CETA standard, which is present in CETA faster.
Okay.
So we can detect early visual field defects.
Okay. So this is 4 minutes and this is 2 minutes.
CETA faster is 2 minutes and CETA standard is about 4 minutes.
About 4 minutes.
Yeah.
Yeah.
Even with less time, it can detect early defects.
Basically, there is a stimulus, there is a duration, there is an intensity. So duration will be the same.
Yes.
Because 0.23 less than before they can test the focus. With more points, how is it faster? That's what I'm just asking out of curiosity, not that it's a question. Anyway, it's all right. Thank you.
Next we have
Hello, 1 minute. You added, you told 10 more extra points or something. You added or mission itself is adding?
But there's no image.
Yeah, in the CETA first part.
Yeah. Next we have Dr. Sarika S. She'll be talking on hyperreflective cystoid diabetic maculopathy, patient profile and treatment response.
Good morning. My paper is on hyperreflective cystodiabetic maculopathy, patient profile and treatment response. Hyperreflective cystodiabetic macular edema is defined as cystoid spaces completely or partially filled with grayish irregular hyperreflective material without backshadowing in the OCT B-scan cross-sectional images. And the importance is it is resistant to treatment and there is a risk of subfoveal migration. And the OCT angiography imaging has detected an extravascular decorrelation signal corresponding to the presence of these hyperreflective contents within the cystoid spaces, and it is called suspended scattering particles in motion. Aim is to study the clinical profile of patients with hyperreflective cystodiabetic maculopathy and their treatment response over one year, and to evaluate the mean change in best-corrected visual acuity, central foveal thickness in OCT, and to assess significance of OCT octa biomarkers following treatment. It's a prospective observational study from June 2022 to November 2023. 64 eyes of 49 patients were included. Inclusion criteria: cases of hyperreflective cystoid center involving diabetic macular edema and eyes with non-tractional DME and willing for a minimum of 1 year follow-up. Excluded taut posterior hyaloid, vitreomacular traction, proliferative diabetic retinopathy, glaucoma, any other non-retinal or optic nerve pathology. And data collected were age, duration of diabetes, associated medical conditions, best-corrected visual acuity at presentation and final follow-up, intraocular pressure, central foveal thickness at presentation and final follow-up, and it is measured with manual caliper tool in the using the Heidelberg spectralis machine. An evaluation of macular ischemia and demonstration of suspended scattering particles in motion by octa was also done. This is octa image showing superficial and deep foveal avascular zone. And the anti-VEGF was dexamethasone implant injections on a pro-rata basis done during the course of the study according to physician discretion. And anti-VEGF injections were given in 35 eyes and OCDS injection given in 29 eyes. Coming to results, The mean age of the study population was 64.6 years and mean duration of diabetes is around 18 years in both the groups. And coming to the distribution of comorbidities, hypertension and dyslipidemia were more in these eyes. A number of injections in the dexamethasone group was 1.96 and in the anti-VEGF was 4.5. A number of visits in the both groups was around 7. And the association of best corrected visual acuity and central foveal thickness at baseline and follow both the treatments significantly improved best corrected visual acuity and reduced central foveal thickness. And the association of foveal avascular zone at baseline and follow-up, there is no change in foveal avascular zone from baseline to follow-up. And the deep capillary plexus size was more than superficial capillary plexus size. And the BCVA change and central foveal thickness change was more in the dexamethasone implant group. And the distribution of SSPIM, total of 51.6% noted SSPIM, and on follow-up SSPIM reduced and the reduction is more in the anti-VEGF group. And the raise in IOP at 1 year follow-up noted in 31% in the dexamethasone implant group and none in the anti-VEGF group. Our observations, the prevalence of hypertension and dyslipidemia were more in these eyes with hyperreflective cystodiabetic macular edema, and during 1 year follow-up, both anti-VEGF and dexamethasone implant showed a significant reduction in central foveal thickness and improvement in best corrected visual acuity were comparable in both the groups. Less number of injections were done in dexamethasone implant group and mean number of visits were almost same in both the groups, and no subfoveal migration or contents of cysts noted. In our study, the prevalence of hypertension and dyslipidemia were more. And study by Ramesh et al. They studied hyperreflective and non-hyperreflective cystodiabetic macular edema and they noted no association of other medical conditions. And in our study, the 31% OCDEX group had IOP spike, which is similar to Dougal et al. Study. And in our study, the mean baseline vision and central foveal thickness reduction was there, mean baseline vision improvement was there, which is similar to Liang et al. Study. And in our study, the deep capillary plexus pore size is larger than superficial capillary plexus size, and it was similar to Koskas et al. Study. In our study, the anti-VEGF group received more injections than DEX group, which is similar to Shah et al. And Gillis et al. Study. In our study, this SSPM decreased in follow-up in both the groups with more decrease noted with anti-VEGF injection. And in Parwana et al. Study, the SSPM continued to persist even after multiple DEX implants, indicating severe blood-retinal barrier breakdown. And coming to the cost of the therapy for 1 year, for anti-VEGF, the mean number of injections was 4.5 and around 1 lakh rupees is the cost for anti-VEGF, and dexamethasone implant is around 77,000. And coming to conclusion, hyperreflective cystodiabetic macular edema responds equally to both anti-VEGF and dexamethasone implant, and this study highlights the beneficial role of steroids as lesser injections are required to manage these eyes, lead to better patient complaints and less financial burden to the patient. These are my references. Thank you.
The cost factor will depend on the type of anti-VEGF.
Yes,
some
sir.
may not respond to bevacizumab, some are have to go for
This is ranibizumab only taken, sir.
but bevacizumab will be lesser.
Yes.
Thank you.
Okay, thanks.
Next, we have Dr. Mohsina T, and she'll be talking on a pathogenesis of primary angle closure disease, the role of crystalline lens, and observational study.
Good morning. My study topic was pathogenesis of primary angle closure disease, the role of crystalline lens. Why the topic is relevant? Glaucoma is the second most leading cause of blindness in the world, and in these 75% of the cases go undiagnosed, and it can be largely prevented through timely identification, appropriate treatment and regular monitoring. And coming to the role of crystalline lens in the PACD, potential mechanism of primary angle closure disease is based on the biometric characteristic of anterior segment. In these, the crystalline lens has a crucial role in the progression of the disease. And now we have imaging modalities like KSOS2024 and optical A-scan biometries. Those are non-invasive methods to determine the role of crystalline lens in the pathogenesis of the disease. And my study aimed to assess the role of crystalline lens in the pathogenesis of primary angle closure disease using KSOS2024 and A-scan biometry. It is done as a case control study at ComTrust Charitable Trust Eye Hospital during a time frame of 6 months from June 2023 to November 2023 in a population of 150 eyes with PACD, primary angle closure disease, and 150 normal age-matched control group. The inclusion criteria based on the ICGO classification for primary angle closure disease in the age group between 40 to 70 years. For controls, we choose normal persons with no shallow AC and normal gonioscopy in the same age group. Exclusion done any patient with secondary angle closure disease or any corneal or iris pathologies, or patient with significant cataract also excluded, and with patients taken any meiotic or mydriatic medications prior to the examination also excluded, and patient undergone laser PI before also excluded, and controls we excluded any kind of glaucoma and with the patient with a significant cataract. We done methodology. Consent obtained and detailed patient history and examination was done. All basic ophthalmological evaluation done, including applanation tonometry, gonioscopy, and HFA 24-2, and also ASOCT and IOL master biometry done all of the patients and control, and we measured lens vault, anterior chamber depth, lens thickness, and all from this investigation. It's a demonstration of ASOCT image of anterior segment. We measured lens vault, anterior chamber depth from the ASOCT, and lens thickness and axial length from the IOL master biometry. Coming to the results, we got a significant huge difference between the case and control group in lens vault comparison, and also we determine lens age. Lens vault is increased in the increase in age. And also relative lens vault, there is a huge difference between the case and control group. Relative lens vault measured as lens vault divided by anterior vault. Anterior vault also, there is a statistically significant difference between the case and control group, and lens thickness also there is a statistically significant difference between the case and PACD group. And also with increase in age, lens thickness increases. Relative lens position, which is measured as lens thickness plus anterior chamber depth plus half of lens thickness divided by axial length, also had a significant difference between the case and control group. Lens axial factor also measured, which is measured as lens thickness divided by axial length into 10, which also has a significant difference between the case and PACD group. Axial length, there was almost similar in both the case group and control group. Coming to conclusion, according to our study, we concluded crystalline lens has a significant contribution to primary angle closure disease pathogenesis, and in these parameters, lens vault and relative lens vault had a significant difference between the case and control group, and there are also other risk factors like older age, female gender, and shorter eyeball and shallow AC depth to the pathogenesis of the disease. And limitation of our study was the age was 40 to 70 years, similar in both case and control, but in control group there are more younger individuals, and PACD patient recruitment, the subgroup was also distribution was a little bit unequal, and also we can't include the acute angle closure disease patient. They all examined after the medical management of acute rise of IOP, but not before laser PI. Recommendation, according to our study, we recommend some ASOCT and A-scan biometry in all patients with the gonioscopy, closed gonioscopy, and recommend early cataract extraction in patient with the significant lens vault and anterior lens position. And thank you.
So it's a good presentation. So ASOCT is a must know. So will all the institutes have ASOCT to measure?
If we
where was this done? Contrast hospital. Okay. So do you use it regularly?
No, madam. We suspect a lens factor to the pathogens of disease. If we done gonioscopy, we doing gonioscopy prior. If it is suspecting more lens-related factor, we can do ASOCT if we're suspecting.
How will you know from gonioscopy whether there's lens related? Okay, when we remove the lens, the AC will become deeper. I'm just asking.
With the patient with the some early cataract
Actually, it's a good thought. It's a good study. Okay.
Can do for everything, then you with a bigger number you will get a question with a control set. Thank you.
The primary angle closure disease, you include all the stages or not? What? You are told primary disease. It includes what? Everything is included there.
Next, we have Dr. Sumina Jabbar, who will be talking on effect of refractive surgery on binocular single vision and ocular alignment.
Good morning all. My topic of presentation today is the effect of refractive surgery on binocular single vision. My topic of presentation today is effect of refractive surgery on binocular single vision and ocular alignment. I have no financial interest. So some of the patients who are undergoing refractive surgery may have a doubt, what will happen to my squint if I undergo refractive surgery? So we know that the refractive surgical procedures help patients with refractive error to achieve spectacle independence. But apart from addressing this refractive status, it can address the binocularity of the patients also. These surgeries, these refractive surgeries can have a positive and a negative impact on binocularity. That is, these refractive surgeries can help some of the accommodative deviations and mild anisometropias can be managed effectively with refractive surgeries. But in some patients, postoperative binocular decompensation can also occur, and this usually occurs in patients with those having pre-op binocular vision issues. The most common reported complaint of binocular vision abnormality after the refractive surgery is the reduction in fusional vergence. Some patients complained of postoperative haze and diplopia after the refractive surgery could be due to these binocular vision abnormalities. So a thorough preoperative evaluation of binocular status is essential in all patients undergoing refractive surgery. Moving on to my study, it's a prospective study of 42 patients who underwent refractive surgery from a time period of April 2024 to June 2024 and with a follow-up period of 3 months. We did a complete ocular examination including cycloplegic refraction, and we assessed the binocular status using Worth-Ford test, stereopsis by Rantot, cover test, alternate cover test before and after the procedure. We also assessed the type of refractive procedure the patient underwent. Moving on to the result, in our study, most of the patients are females, that is 64.3 are females and 35.7% are males, and the age group ranges from 18 to 34 with a mean age of 24.6. That is, most of these patients are in either students or in a productive age. And 84% of the patients underwent LASIK surgery, 16% underwent LASIK surgery. All patients in our study who underwent surgery were myopes. None were hypermetropes, and with an average spherical equivalence of minus 3.4 diopter sphere in the right eye and minus 3.2 diopter sphere in the left eye. Among 15 patients who underwent, who has a preoperative exophoria for near, preoperatively, 12 patients continue to have this exophoria for near after the procedure, while 3 patients exophoria resolved. And in 10 patients who were orthophoric for near before surgery, developed exophoria for near after the surgery. We have a patient with intermittent divergent squint with good control before surgery, and he continues to have this intermittent divergent squint with good control after the surgery also. And vision improved to 6/6 in all patients in our surgery. Fusion and stereopsis were maintained after the surgery in all patients. In our study, none of the patients developed manifest squint after the surgery. So moving on to discussion, refractive surgeries can have a positive and a negative impact on binocularity, as by correcting the refraction, mild accommodative squints and mild anisometropias which can cause binocular vision abnormality preoperatively can be addressed by these refractive surgeries. But these refractive surgeries can cause diplopia and other binocular vision abnormalities, like these surgeries can cause monocular diplopia due to decentered ablation and binocular diplopia due to the decompensation of foria to large topias postoperatively. and some of the refractive surgeries aiming at monovision with high anisometropy of more than 1.5 diopter can precipitate these binocular vision abnormalities. So in this small study of myopic patients who underwent LASIK and LASIK surgery, majority of the patients with exophoria for near continue to have exophoria after the procedure, while in 3 patients exophoria resolved. One finding is that 10 patients who were orthophoric before surgery developed exophoria for near after surgery despite a normal near point of convergence. This could be due to a sudden change in the accumulative effort need to be activated for near vision. So orthoptic evaluation and long-term follow-up should be done in these patients to assess whether exophoria improves or it decompensates to exotropia. In our study, a patient with intermittent divergent squint with good control before surgery continue to have this intermittent divergent squint with good control after the surgery. But there are reports which shows that Mandava et al. Reports a case who developed diplopia due to decompensated exotropia 9 months after a refractive procedure. Schuler et al. Reported a patient with vertical and torsional diplopia caused by decompensated congenital superior oblique palsy immediately after a LASIK surgery which aims at monovision. Yap and Kowal describe a patient who presented with exophoria preoperatively, developed vertical diplopia and after LASIK surgery that was decentered. The limitations of my study, we included only patients underwent LASIK and LASIK. Other procedures are not included. We have only myopic patients, no hyperopic were there. And the short duration of study, small sample size and short-term follow-up, because follow-up is essential to know the cause of these errors. So, significant binocular vision abnormalities are not noted in our study, but a thorough binocular vision evaluation preoperatively and postoperatively is recommended in all patients undergoing refractive surgery to avoid postoperative surprises. Thank you.
Different study, ma. Good one, different. Thank you.
Thank you.
Next we have Dr. Remy Singh. And she'll be talking on to correlate clinical features vision with SD-OCD changes in patients with myelinated nerve fibers.
Good morning all. My topic is to correlate clinical features, vision and SD-OCT changes in patients with myelinated retinal nerve fibers. So myelinated retinal nerve fibers is a benign congenital anomaly in which the RNFL anterior to the lamina cribrosa have myelin sheath. It is a defect in the lamina cribrosa which allows oligodendrocytes to gain access to retina. It is seen in up to 1% of population and 7% of the affected patients have bilateral involvement. Clinically, it appears as white striated patches at upper and lower poles of the optic disc, and it is an irregular fan-shaped. It is irregular fan-shaped in appearance. OCT shows a hyperreflective retinal nerve fiber layer. The aim of the study is to correlate the clinical features vision with SD-OCT changes in patients with myelinated retinal nerve fibers. It is a retrospective study of all the patients with MRNF from January 2015 to October 2022. The inclusion criteria, it included all the patients with myelinated retinal nerve fibers with documented fundus and SD-OCT images. The data collected included age, gender, the visual acuity, refraction, slit lamp examination, anterior segment, posterior segment, the laterality, quadrant and macula involved. Investigations were fundus photo and SD-OCT. Out of 26 patients, the age group was between 11 months to 75 years. And majority, out of 26 patients, majority of them were males, 18 of them were males and 8 were females. Laterality, 20 patients showed unilateral involvement and 6 patients showed bilateral involvement. The visual acuity, the average visual acuity in eyes with myelinated retinal nerve fibers was 1.1 logmar, and the range of visual acuity was between 6.6 to counting finger at 1 meters. The average spherical equivalence in patients with myelinated retinal nerve fibers of the right eye was -5 diopter sphere, and in left eye it was -2 diopter sphere. The range of spherical equivalence in eyes with myelinated retinal fiber was -12 spherical equivalence to +0.2 spherical equivalence. Most of the patients were myopes among the study group. Among 26 patients, 22 patients were myopes and 4 patients were hypermetropes. Amblyopia in MNF. Among 12 amblyopes, all were myopes, and among the 12 myopes, 12 amblyopes, 4 patients had Strathmore syndrome, which was unilateral or bilateral MRNF with axial myopia and amblyopia. 1 patient had reversed Strathmore syndrome, which was unilateral MRNF with hyperopia and amblyopia. Among 12 amblyopes with MRNF, 6 patients had extensive myelinated retinal nerve fiber, which was 4-quadrant involving and the posterior pole. 1 patient had exotropia with MRNF, which was involving the posterior pole. 9 patients had anisometropic amblyopia. Under anterior segment examination, 22 patients were within normal limit, 2 patients had cataractous changes in lens, and 2 had strabismus, which is exotropia and esotropia respectively. Posterior segment and quadrant and macula involved. The OCT finding of all the patients with MRNF had retinal nerve fiber thickening, and there were 6 patients who had 4-quadrant and posterior pole involved, and 8 patients who had more than 2 and equal to 2-quadrant involvement, and 12 patients had less than 2-quadrant involved. In case 1, it was a 14-year-old female who had BCV of right eye, counting finger 2 meters, and left eye 6x vision with normal anterior segment finding, and the right eye fundus showed extensive MNF all along the arcades. The OCT showed RNFL thickening and hyperreflectivity, and the inner retinal structures could not be visible. The second case was a 21-year-old female whose BCVA was right eye 660, and anterior findings were normal, and the fundus showing MNF, which invading the posterior pole. The OCT shows RNFL hyperreflectivity, and there was altered inner retinal structures. Case 3, it was a 32-year-old male who had BCV of right eye 6.6 and left eye 6.9 with normal anterior segment findings, and the fundus showing left eye extensive MNF all along the arcades. The left eye OCT shows RNFL hyperreflectivity and altered inner retinal structures. This retrospective study reports the visual outcome of patients with MRNF depending on the quadrant, macular, and OCT findings. The impact of myelinated retinal nerve fibers on visual acuity is highly variable and depends on the extent of myelination patches or if the macula is involved. Optic nerve abnormalities such as dysplasia, hypoplasia can be coexistent. In the study of 26 patients with MRNF, 6 patients with 4-quadrant MRNF had vision ranging from counting finger 1 to 160. 3 with macula involved had vision ranging from 660 to counting finger 1. 12 patients were amblyopic, and amblyopia due to anisometropia were given proper glasses and patching. Strabismic amblyopia were also managed with eye patching, glasses, or eye muscle surgery. Our observation was that despite adequate optical and amblyopia therapy, those with 4-quadrant and macular involvement did not improve in their vision, proves the fact that amblyopia is not entirely anisometropic but also due to sensory deprivation due to structural alteration in retina. Conclusion: the MNF involving all arcades and macula involved have a greater impact on visual outcome compared to less involved cases. These are the references.
Good study, ma. Something related to neuro finally. Thank you.
Thank you. Next we have Dr. Durga Rani, and she'll be talking on a study on posterior segment of risk factors in closed globe injury with hyphema patients.
Good morning all, I am going to present a study on posterior segment risk factors in closed globe injury with hyphema patients. Introduction. Ocular trauma is the leading cause of preventable visual impairment and blindness. Blunt trauma of eye can lead to various intrinsic ocular injuries. Hyphema is defined as blood in anterior chamber, which is a common manifestation of blunt trauma. Severity of damage is directly proportional to severity of trauma. Blunt impact force in closed globe injury leads to coup and counter-coup injuries resulting in posterior segment sequelae which are associated with poor visual outcome. Objective of my study is to determine trauma-related posterior segment risk factors for poor visual outcome in patients who presented with hyphema following a closed globe injury. It is a prospective observational study conducted in Government Medical College, Kottayam in patients presented with hyphema following closed globe injury during a study period of 1 year in 48 patients. Those who presented with trauma-related posterior segment risk factors in hyphema patients following closed globe injury in the age group of 18 to 60 years were included, excluding with those with pre-existing ocular diseases and with history of previous ocular trauma and surgeries. Study procedure: patients with hyphema following closed globe injury satisfy inclusion-exclusion criteria were taken and best corrected visual acuity is graded, and pupillary examination is done to look for RAPD, and slit lamp examination is done to look to grade the hyphema, and indirect ophthalmoscopy is done to look for retinal tears, macular hole, vitreous hemorrhage, Berlin's edema, choroidal rupture and hemorrhages. If media is hazy, B scan is done to look for RD, CD and vitreous hemorrhage. Appropriate medical and surgical treatment is given wherever possible, such as IV methylprednisolone, pars plana vitrectomy, buccal and Barrett's laser. Visual acuity is assessed after 6 months. Best corrected visual acuity, if it is more than or equal to 612, is taken as good outcome, and less than or equal to 618 is taken as poor outcome. A total 11 patients presented with vitreous hemorrhage. Out of 11 patients, 8 patients had good outcome, 3 patients had poor outcome. Total 6 patients presented with traumatic optic neuropathy. All 6 patients had poor outcome. Out of 8 patients presented with retinal detachment, 3 had good outcome and 5 had poor outcome. Out of 15 patients presented with retinal tear, 11 had good outcome and 4 had poor outcome. Out of 8 patients presented with macular hole, 5 had good outcome and 3 had poor outcome. In my study, 90% of the patients were male, mostly in the age group of 26 to 40 years. Most common mechanism of injury was assault followed by workplace injury. Most common risk factor was retinal tear followed by vitreous hemorrhage. Poor visual outcome in my study was traumatic optic neuropathy followed by retinal detachment. In Jakarta eye trauma study, poor outcome was due to vitreous hemorrhage and choroidal rupture. In Koje et al. Study, poor outcome was due to macular edema, epiretinal membrane and choroidal rupture. In Jaiswal study, poor outcome was due to vitreous hemorrhage, macular hole and retinal detachment. In Kalfan Ali et al. Study, poor outcome was due to macular edema and macular hemorrhage. Conclusion: trauma-related posterior segment risk factors are the major contributing factors for poor visual outcome in patients presented with hyphema following a closed globe injury. Early recognition of factors related to poor visual outcome, timely appropriate medical therapy and surgical intervention when indicated, and careful follow-up helps in preserving vision. Wearing protective goggles at workplaces helps to decrease ocular morbidity. These are my references. Thank you.
Your primary inclusion is hyphema. So irrespective of hyphema, traumatic optic neuropathy or RT will have the same kind of outcome. Will hyphema have a bearing on the outcome? Number one. Number two, due to hyphema, was there any glaucoma? Was there any blood staining? So those things also matter, isn't it? Hyphema is your primary finding, but you're given outcomes of the associated findings. You didn't talk about what happened to the face. You're given all grades of hyphema, including H4 like that. So was there anything there where you had to intervene for hyphema, or if you're not intervened, was it glaucoma or anything like that? You're not mentioned in your study. Hyphema outcomes you're not mentioned. No, I'm just asking you. Only the associated features outcomes you've seen, isn't it? Thank you.
Thank you, speakers, and thank you to the judges. Yeah.
So thank you, scientific committee. Thank you, organizer of this hall and all of KSOS for this opportunity. Congratulate all the presenters. You all done a very good job. You have a bright future. All the very best, irrespective of who goes to the final wins.
All the very best. All were good presentations. We really enjoyed. Thank you.
Really great presentations, and really we had a nice time yesterday also, today also, and I think 1 o'clock, 1:30 also we'll be having more funny part of this thing. Okay.
Next, I would